Foremost, I would like to invite Dr. Amir Kashani, who is a private cardiologist in practice on the west side of Houston, Memorial West, but he keeps a leg here at Houston Methodist, and we are very appreciative of that. He's a expert at atrial fibrillation, stroke prevention, and devices which can be utilized to prevent those. I'd like to invite Dr. Kashani. Yeah, that's
Does it point?
Yeah, that's it.
Is there a pointer? Oh, there. Hi, good afternoon. Hopefully you still have some energy to go through a couple more talks. So I didn't realize that there's a question and answer session at the end of each block, so I had actually intended to allow some time for people to ask questions, so please, if you have questions, I guess text them in as the strategy that we're having this afternoon. Is it the green button that advances? All right, perfect. Okay, so I think by this time in the era of anticoagulation, everybody's pretty familiar with the NOACs and the newer drugs that are on the market. But probably one of the things that people are less familiar with are the devices and the procedural techniques that currently exist in preventing stroke in atrial fibrillation patients. If you really take a look at, thank you. If you take a look at your overall patient populations that you have out there, there is a large number of AFib patients who, for a variety of reasons, are unable to be treated with anticoagulation, whether it be a bleeding event that they've had or just overall comorbidities and issues that they have that makes them high risk for anticoagulation. Quite frankly, a very significant number of patients just simply don't want to take anticoagulations because of the way it makes them feel and because of the side effect profiles that it has. To be honest, one of the reasons that I am fascinated with this technology and have taken such a liking to it is because when I was a resident and I used to watch the patients who are on anticoagulation have issues with them and need to stop them, I used to always think to myself how cool it would be if someone would invent something that would replace anticoagulation so that these patients wouldn't have to take the blood thinners. And I guess 15 or so years later, here we are. So currently, there is one device that is FDA approved and on the market and ready to be used. There's another one that is called this is the Watchman, the picture up there. That's the one that is currently FDA approved and we're using it. The second one is an Amulet device, or the name of it is Amulet. It's made by St. Jude, and Houston Methodist is actually the only site in Houston that's part of the clinical trials, and we are actively implanting as part of a research trial for that. So I'd like to very briefly go over some of the data out there and kind of introduce it to you and show you how it's done and have you keep it in mind for your patients. This talk, I usually give it in about an hour, so I'm going to try to condense it down. If you find me talking too fast, let me know. I can slow down or back up. So as you know, atrial fibrillation increases the risk of stroke. This is an echo picture. I'm not 100% certain if, does this travel? I guess not. So this area here on this echo image is the left atrial appendage. And this circle that you see here is an actual clot that's inside the appendage. There have been several studies, most of them many years ago, that perfect, that'd be great. That have shown that greater than 90% of thromboembolic events in atrial fibrillation come from the left atrial appendage. There are studies that show anywhere from 95 to 99% of thromboembolic events in patients with AFib originate in the left atrial appendage. So if you were able to exclude the left atrial appendage, you would eliminate that percentage of strokes from AFib. This is an actual heart itself. This area here that you see, this lobe, is the left atrial appendage. And as you can, when you look at it, it looks so different than that picture did a moment ago on the echo. On the echo, it looks like just a very smooth pouch that kind of sits there and doesn't have any issues, you wouldn't think, based on that picture. But when you look at the left atrial appendage itself, you can see how it has edges and it has lobes, and it's quite a complex structure, actually. It's quite fascinating because for years, we didn't have any reason to go inside the left atrial appendage and take any pictures of it. So to be honest with you, I never really appreciated from the echo views how complex the left atrial appendage is until we started doing these procedures and we go inside and we take a picture. And equally as different as every single one of us in this room are, the left atrial appendage in every single person is an absolutely different and unique structure. It's quite fascinating, actually. This is a cutout of the inside of the left atrial appendage, and you can see how trabeculated it is. And you can imagine in a left atrium that has a fib and the squeeze of the atrium stops and the blood becomes stagnant, you can see how within this trabeculation, stagnant blood can become quite easily a clot, which can subsequently travel. This is the same structure. If you just push on it, you can see the actual wall of the left atrial appendage is quite thin. You can actually see the glove, the green parts of the glove, through the walls. But it's the trabeculation that makes it thick and causes the issues. Now, to back up for 1 second, the risk stratification in atrial fibrillation of who needs anticoagulation and who should have anticoagulation and who shouldn't, historically, we used to use the CHAD score. But as I'm sure you're aware, in the last few years, they've developed a new score, which is the CHADS-VAS score. Each letter stands for something: the C, congestive heart failure, hypertension. There's two separate age groups, the two A's. Age greater than 75 gets 2 points, 74 and under gets 1 point. Prior strokes, TIAs or thromboembolic events, diabetes. The female sex actually is a risk in clot formation. The CHADS-VAS score has clearly been proven to be a better tool in assessing a patient's risk. We still use the same number that any patient with a CHADS-VAS score of 2 or greater should be anticoagulated or be considered for anticoagulation. The Hasbled score is a score utilized to risk the scoring, the risk profile of patients for bleeding once they are anticoagulated. That involves things like hypertension, abnormal liver or renal function, previous hemorrhagic events, labile INRs on Coumadin, elderly patients, patients requiring medications such as aspirin and Plavix, patients with coronary disease who've recently perhaps received a stent and now are on dual antiplatelet agents, but then they develop atrial fibrillation and they need full anticoagulation on top of that, for obvious reasons, increases the risk of bleeding. These scores, you have to realize both of them, both the Hasbled score and the CHADS-VAS score are a cumulative risk. So every year that goes by, the risk of stroke increases on a linear fashion, as does the bleeding risk. So if you take the Hasbled score, you see on this first column here is the score itself. So an annual risk, let's take a Hasbled score of 4. On an annual risk, the risk of bleeding is 8.9%. But when you calculate that on a 10-year format, you're looking 10 years down the line an approximate 60% risk of bleeding in the patient who's been anticoagulated for 10 years. And the sicker these patients get and the older they become and the more comorbidities they have, that risk clearly goes higher. This is a very fascinating, at least to me, it's a very fascinating slide. Just to orient you to it for a second, on the axis here, we're looking at the percentage of patients that are anticoagulated. At the bottom is the CHADS-VAS score, 0 to 9. Focus, please, just on the blue and the gray, or the brown. The first two colorings. These are the patients who are on either Coumadin or one of the newer anticoagulants. And as you can see, it's a kind of a bell curve. This lower end receive an appropriate amount of anticoagulation based on their risk. The patients in the middle are the patients who are getting the most anticoagulation percentage-wise, so in the 4, 5, 6 range. But as you start to reach the 6, 7, and 8 range, these patients become sicker patients with more comorbidities and a significantly higher risk of actually having a thromboembolic events. However, the percentage of patients that remain on anticoagulation or are given anticoagulation progressively decreases the sicker they become. So the patients who actually would benefit the most end up getting the least amount of anticoagulation. Intuitively, that makes sense. They're sicker, they're older, they have more comorbidities, the risk of bleeding is higher, so people are anticoagulated less. This slide shows the amount of patients that stop anticoagulation on their own or for a reason. So if you look on the zero down here is 100%, but by 2 years, the green line is the Coumadin patients. By 2 years after initiation of therapy, almost 50% of these patients have stopped their anticoagulation for some reason or another. The red line is the NOACs, the newer anticoagulants, such as Eliquis, Pradaxa, Xarelto, those kinds of things. And by 2 years down the line, these patients, about 30% of them have stopped that usage of their anticoagulants for some reason. So this is where left atrial appendage closures come into play. So rather than having your patients on anticoagulation, they can have their left atrium closed and subsequently not need anticoagulation anymore. The studies that have been done show that the left atrial appendage closure devices are equivalent to Coumadin use. Unfortunately, none of the studies have been done with the NOACs because when the technology was started approximately 10 to 12 years ago, the NOACs weren't around. So most of the studies that we have are in comparison to Coumadin. This is essentially what it looks like. So what we do is, oh, wait a minute. So this here is the left atrial appendage. That's the catheter coming through the transeptal, and that's where the Watchman device gets deployed. This is not actually showing all of my slides, but that's okay.
If you need to play it, you need to play it.
No, it's just skipping for some reason a couple of my slides. It's okay. So essentially, it's a percutaneous procedure. It's just a needle stick in the groin. We go in the vein, so the risk of bleeding is arguably less than even a coronary stent, since we're in a vein rather than an artery. We do a transeptal puncture exactly the same as when the electrophysiologists do AFib ablations, and we pass a catheter and position it in the left atrial appendage and deploy the Watchman device, which sits at the beginning. And then in the course of about 6 weeks' time, the body builds fiber tissue naturally on the face of the Watchman. This actually is an autopsy patient 9 months after an implant of a Watchman. The patient did not die from causes of the Watchman, fortunately. And you can clearly see, I have an arrow to it pointing at it. You can clearly see how the Watchman is completely endothelialized and fibrosed over, and the appendage is completely closed. Now, more recently, the Watchman has really been approved, I believe, if I'm not mistaken, approximately 2 years now by the FDA, and maybe a little bit longer, and is approved for usage. This is an Amulet device. It's produced by St. Jude, and this is what it looks like. It's slightly different. The Watchman, this is the Amulet itself. The Watchman here on your left, as you can see, completely sits inside the appendage. The Amulet has 2 discs. The first disc sits inside the appendage and anchors it so that it doesn't move. The second disc sits actually outside the appendage and seals off the appendage from the outside. We don't have any clinical data from the United States. We're currently accumulating, as I told you, we're part of it, but we do have some data in Europe and Canada. The Amulet device has been used in Europe and Canada for a number of years. This is a PCR registry that was done in Europe. The average CHA2DS2-VASc score was 4.2. The Hasbled score in these patients was 3.3. They had 1,088 patients in the trial, and less than 5 millimeters of leakage from around the device is the standard for the Watchman. And in their trial, they had 100% closure of less than 5 millimeters at implant and 99.9 in the 1 to 3 months after implant. This is the data they have. If you look just on the 2 graphs on your right-hand side, you can see that the the device lowered the risk of thromboembolic events after implant by approximately 60%. If you look at some of the older Coumadin data on how much Coumadin usage in anticoagulation lowers the risk of thromboembolic events in AFib patients just on anticoagulation, it's about 2/3. So 60% is similar to that. The current issue immediately after implant of the usage of anticoagulation. So for a Watchman device, immediately at the time of implant, we put them on 81 milligrams of aspirin and either Coumadin or one of the NOACs for 45 days. We do a transesophageal echo at 45 days to evaluate the device and make sure that it's completely sealed, and then the patients can stop their anticoagulation, and they'll be on aspirin and Plavix for 6 months, and then aspirin subsequent to that. Now, to be honest with you, since the FDA approval of the Watchman on patients who we consider to be on extremely high risk and perhaps can't tolerate that 45 days, we do have some off-label strategies that we have utilized, and we have some registry data and some data from Europe. And there's actually a clinical trial here in the US now trying to cut that 45 days of anticoagulation down or eliminate it completely. For the Amulet, from the time of implant, patients are placed on aspirin and Plavix immediately, so they don't need that 45 days of full anticoagulation. I see my time is running low here, so I'll skip a couple of these. So when it comes to patient selection, this is what the FDA has published. It's available really anywhere you'd like, and I can tell you where to find it if you want me to later, so I won't read it for you. You can read it yourself. But essentially, any patient who, for any reason, you either deem them too high risk to start on anticoagulation, or they've had a bleeding event, or quite frankly, if they simply just are refusing to take anticoagulants, these are the patients that as long as 2 physicians have discussed it with them, so the referring physician can be one and the implanting physician can be the second, as long as the patients have had a fair chance to hear about it and discuss it and understand the risk and benefits of it, they can be considered. I know I'm about a minute over here, so I'll try to cut it short and leave questions for later. Thank you very much for having me. I appreciate it.